at this point, we know that some paramagnetic substance will lead to a decrease in signal amplitude on an image that is sensitive to these magnetic susceptibility effects, right? Which is most commonly going to be a T2 star sensitive or weighted image. And we've already said that we can choose to use this type of T2 star weighted image to generate some diagnostic information. If you want to detect small areas of hemorrhage or calcification, that's the type of image that you want to choose. So what I want to talk about now is inducing this effect by injecting a paramagnetic substance, right? Gadolinium-based contrast agent, to deliberately cause this type of signal loss and to use it to extract some diagnostic information, specifically some information about physiology. And this is about perfusion imaging. So if we inject a contrast agent, which is paramagnetic, like gadolinium, and let's say we have our patient lying in the scanner, and we're going to image the brain. So let's say we're going to image this one slice of the brain. And our image looks like this. And we can choose some region of the brain that we're interested in. If we acquire that image using whatever technique, gradient echo, spin echo, pick it, whatever you want, and we measure some amount of signal intensity at that location, some amount of transverse magnetization. Let's now give a contrast injection and do the same thing again. Acquire the same image and measure that signal intensity. So we now have 2 points in time. How is the signal amplitude acquired at that location going to differ between time 1 and time 2? In general. If you had to... Well, the answer is it depends, right? So the answer is it depends on the type of image. Okay? So first of all, if this would be a T1 sensitive image, we would expect that there's gadolinium in the tissue at the time we acquire the second image, causing that proton-electron dipole interaction, acceleration of T1 relaxation, and increase in the signal amplitude. If, on the other hand, I chose an image that's sensitive to T2 star, what would the signal look like? Would there be any effect? Let's say I'm doing a regular MRI of the brain, and I do my gradient echo image of the brain. We do it all the time. And then I give the patient a gadolinium injection, and I do it again. And I compare two regions of interest, exactly what I've shown you here. And I compare the signal on the pre-contrast T2 star weighted image and the post-contrast T2 star weighted image. Will there be any difference in the signal intensity? Yes, no, maybe? Well, we're using gadolinium as our contrast agent. We've already said that gadolinium has many unpaired electrons, and that as a result of that, first of all, those unpaired electrons can lead to this proton-electron dipole interaction and cause shortening of T1, but they also lead to gadolinium having a very high degree of paramagnetism. Its magnetic susceptibility is very high, which means that the presence of gadolinium contrast leads to variability in the static magnetic field, dephasing and loss of signal. So we would expect that there would be lower signal amplitude the second time we do this T2 star weighted imaging relative to the first time, simply because of the presence of the contrast agent. Question?
Yeah. Didn't you say that it had to be localized when we're talking about the iron and the difference between whether it was diffuse or whether it was actually creating?
Okay.
So,
true.
Okay, so how would you apply that concept to gadolinium?
Well, what I would say is that what determines within that little volume of tissue the distribution of the gadolinium contrast agent? We inject it intravascularly. Right? Different amounts are going to go to different parts of tissue. If, for example, this contains some veins and some arteries and some capillaries and some tissue and some cerebrospinal fluid, right? Different components of that volume are going to take up different amounts of the contrast agent. So you're exactly right. There will be a gradient of magnetic susceptibility. If, for some reason, the gadolinium was absolutely uniformly distributed across the brain, then we wouldn't see any effect. But that's not the reality. Whenever you deliver a contrast agent intravascularly, the same amount doesn't go everywhere. If we wanted to maximize our ability to see this difference, what would you do? Well, you'd choose a type of image that was very sensitive to those differences, first of all. Secondly, we would use a lot of this stuff. Right? If there's a ratio between how much of the contrast agent gets to one part of the tissue and how much gets to another part of the tissue, the larger the volume of contrast we deliver, the greater the absolute difference in concentration of the contrast at those two locations. Essentially, this change in signal is proportional to the local concentration of the contrast agent. So if we make things a little bit more complicated now and say, I have my patient and I'm going to image this slice in their brain. But now what I'm going to do is, over a period of time, I am going to image their brain multiple times. So I'm going to use some very fast imaging technique that's very sensitive to these magnetic susceptibility effects. Something like gradient echo, echoplanar imaging would be one potential choice. You could use fast gradient echo imaging. You could use whatever you want. And let's say we image, right, at intervals of 1 second. So we could plot the signal amplitude, the signal intensity, from some particular location in that image and watch what happens to that signal intensity over time. 10 seconds is probably too short for this to be a realistic example. But let's say we're going for, 100 seconds or whatever it is. So at the outset, we would have some baseline signal amplitude which is just the gradient echo echoplanar signal from that tissue. If at this point in time we inject our contrast agent, which takes around 15 seconds or so, 20 seconds to get from the arm into the brain, what would happen to the signal amplitude after the contrast arrives? It's going to go down. And it is going to continue to go down until the point in time at which the maximal concentration is reached at that location in the brain. And then as time goes on, the contrast bolus will wash through the tissue. The contrast concentration is declining at that point in time, and we will get back up to our baseline. So if we look at the trajectory of what's happening, we've shown that there is a decrease in concentration, a decrease in signal, which corresponds to an increase in the concentration of the contrast agent that we can watch in real time. So we're essentially watching the first pass of a bolus of a contrast agent. In order to do this, we need to image very quickly. We need to image with an approach that is sensitive to these effects. And if we want to maximize our sensitivity, the two things we can do are to use the most sensitive imaging technique and to use the largest amount of contrast that we can. It's also important that we give this contrast as a very compact bolus. Because let's say we just hang it up in a bag and let it drip into the arm. What's going to happen? This is going to be, the slope of this change is going to be broadened. Right? If we want to observe this type of an effect, ideally we want to provide this contrast instantaneously, which is never realistically achievable. But typically to do this, we inject the contrast at around 5 cc's per second. Some people inject it even faster than that. If you inject too slowly, this thing just gets diluted and stretched out. Right? And this is how we do perfusion imaging in the brain. Now this is a measurement from one location. Since we have an image, right, we have an entire image of many voxels acquired at each of these points in time. We can compute or plot this curve for each and every one of these voxels. And if we have many slices, we can do it for every slice. So we have the ability now to look at the real-time hemodynamics at every location in the brain, assuming we have enough slices. Okay. From this information, we can make a whole bunch of semi-quantitative measurements of the hemodynamics of what's happening in the brain. We can look at the time, right, to reach this maximum decline in signal, which is called the time to peak. Right? We can look at how long it takes from the injection of the contrast till we first start to see a decline in signal, which is sometimes called T0, or is called the arrival time of the contrast bolus. If we take the integral of this area, this is proportional to the intravascular volume of contrast, or what's called the cerebral blood volume. And if we take an estimate of the width of this deflection in the time signal intensity curve, right? This is called the mean transit time. And each of these pieces of information can be used to make different diagnostic inferences about the patient. If you're looking at a tumor, for example, the cerebral blood volume is very important because aggressive neoplasms generate their own blood supply and have a higher intravascular volume than normal brain tissue. If you're interested in stroke, things that tell us about the timing of the bolus are much more important. So things like the time to peak or the mean transit time are the parameters we'll look at. But basically, by giving a contrast injection and watching for a relatively brief period of time, I mean, this entire process happens in well under 2 minutes. Might be less than a minute, depending on how you want to do it. You can derive all of this information. All right, any questions about this? Now, the basic mechanism here, by the way, is that this is what we call right, an indicator dilution technique. It's the same idea, right, if anyone ever worked in an ICU where they do cardiac output measurements by injecting cold saline into the Swan-Ganz catheter. They still do that? Sound familiar? The nurses usually do it, so maybe you guys didn't actually have to do it. You're just injecting, right, some contrast agent, something to measure how it affects your signal later on. And it can give you all of this hemodynamic information. Okay? So this is an example of what the images and the data actually look like. This is often called, by the way, dynamic susceptibility contrast MRI. Dynamic because we're looking at a real-time signal, and susceptibility contrast because it's a function of the magnetic susceptibility effect of gadolinium. So here are 3 sample images. These are gradient echo, echoplanar images from different points in time. As we image the brain with a temporal resolution of about 1 second between scans, and there are a total of 43 scans. So you can see the baseline signal. It looks like a T2 star weighted image. Once the contrast arrives, notice how where the sulci are located, where all of the vessels are, we have this loss of signal. And then after the contrast is gone, we have a signal which is more similar to initially, but it doesn't actually completely reach its initial baseline. The reason for that is twofold. First of all, there is some contrast that leaks across the capillary membrane. So the gadolinium that we use is not a purely intravascular agent, and there is always going to be some persistent change in signal. Second is that there may actually be some persistent intravascular effect due to different velocities of flow in different components of the image. Okay, so here is, I'll just give you 2 different examples. First of all, on the left, what I'm showing you is those curves, right, time intensity curves, which have been transformed into a time concentration curve. It's the same thing. The signal intensity changes in proportion to the local contrast. And this just shows you how we can perform different hemodynamic measurements on this data. Here's an example. I think I actually showed you guys this example the other day or a week or 2 ago. This patient has a stroke, right? Diffusion weighted image at the top, ADC image at the bottom. It's white and low ADC because there is dramatically restricted diffusion. If we look at a hemodynamic image, so what we've done to create this image is compute a curve like this for every single voxel in the image and measure, in this case, the time to peak for every single voxel, the time to get to this greatest deflection of the hemodynamic curve. Make a quantitative measurement in seconds for each of those voxels and plot it on a color scale. So our time to peak is longest, right, in this middle cerebral artery territory on the left side. Now the clinical point here is that the area that has an abnormally delayed uptake of the contrast is much larger than the area of the diffusion abnormality. So our understanding is that the diffusion abnormality tells us that this is no longer viable tissue. It's completely infarcted. The perfusion information tells us that there is impaired blood flow to these areas. Right? The fact that we have this large periphery which has impaired blood flow but is not yet irreversibly infarcted is what we call a penumbra, or brain at risk. This large periphery which potentially could go on to have the same fate of infarction as this one. And the curves in the lower right are just showing you 3 regions of interest, right? The purple one from the normal side, showing an earlier arrival. From our hemodynamically impaired tissue in light blue, there's a significant delay. And then in the core of the infarct, we don't see any change at all because there's no perfusion getting there in the first place. So here is one more example of a patient with a tumor, right? Pre and post contrast images. This is one of our raw time series images showing that there is some signal attenuation within the lesion, but most importantly, showing us the locations at which we are plotting these two curves. Right? Number 3, in the normal side, the area inside that dip in signal amplitude that occurs due to the arrival of the contrast is dramatically smaller relative to what is coming from the side where the tumor is. Right? The image up here is a cerebral blood volume image. So for every voxel in the image, we plot this curve, take the integral to compute that area under the curve, and place it on a grayscale. So this area, which is higher on the grayscale than the comparable contralateral side of the brain, is area that's infiltrated by tumor, even though it doesn't show up yet as contrast enhancement or signal abnormality on the structural images. So this is actually a way for us to much more sensitively detect early infiltration by tumor, but most importantly, right, allows us to say something about the nature of this tissue. This pattern of elevated cerebral blood volume is something that we expect to see in a neoplasm and not in other types of pathology. So any questions about this? Okay. You know what, let's look at one more example. This is another case, right, with contrast-enhancing abnormalities in the brain, using perfusion imaging to compare these areas of contrast enhancement to normal-appearing homologous areas in the other hemisphere. This is a patient that has a known tissue diagnosis of an astrocytoma that was treated with radiotherapy. When we compare the two sides, right, number 3 and number 5 up here are the normal side of the brain with much larger cerebral blood volume than the area of contrast enhancement on the abnormal side. Right? So this is the pattern that we see in people who have radiation necrosis. So this distinction of area under the curve correlating with cerebral blood volume is telling us something about the nature of what's going on, which you can't infer from structural changes like contrast enhancement. Contrast enhancement occurs in both cases. Okay. This is, I just wanted to show you one example of a different approach to hemodynamic imaging. So this is breast imaging. And in imaging tumors in the breast, we take a different approach. I shouldn't say we, I don't do this at all, but a different approach is taken than when we do, for example, the type of perfusion imaging we were just talking about in brain or in other solid organs. In that, in these cases, they specifically look at the T1 effect of the contrast agent. So what we're looking at here is change in signal intensity over time. And we notice that unlike our perfusion imaging in the brain, we're seeing a progressive increase in signal over time. So this is simply looking at the T1 effect. The sort of salient point I want to make mention of is that the time scale over which this is done is totally different from what we do in perfusion imaging in the brain. Here we're looking at things at increments of perhaps a minute or even more, right? Just trying to detect this T1 perfusion change in the breast, and this appearance of a gradual uptake and a persistent plateau, right, is supposedly suggestive of benign lesions as opposed to malignant lesions, which have more of a large uptake and a rapid fall off in their T1 related signal. So it's the same idea of watching this, right, in a temporal manner, but it's not the same sort of real-time approach to imaging.
The T2 star effects,
yes,
happen faster?
It's not because the T2 star effects happen faster. That has nothing to do with it. It simply has to do with the nature of the pathology. And it's not that the T2 star effects happen in the same time frame. I think that it has to do with the hemodynamic uptake of the tumor. So it's a physiology thing. It's not a physical effect. When you give a contrast agent, right, and you do a T1 weighted image, the change in the actual signal in proportion to T1 shortening, that happens instantaneously. What it depends on is how long does it take for that contrast to infiltrate in and get up into the object or the pathology that you're interested in looking at. So in the T2 star perfusion, we're looking at a vascular effect. Here we're looking at an impact of the gadolinium on the T1 of the tissue. So it has to do with accumulation of gadolinium in the tissue as opposed to transit of the contrast agent through the intravascular space. Okay?